Hello, I am Dr. Anand Mamdani from the Department of Neurology. This is the fourth module in the series of Altered Mental Status. It focuses on neurological examination in coma patient. This module has 6 objectives. After finishing this module, you should be able to explain neurological examination in patient with coma, describe Glasgow Coma Scale, describe respiratory patterns associated with coma, discuss anatomical pathways for brainstem reflexes and normal function, describe motor examination in patient with coma, and identify various neurological findings related to etiology of coma. Neurological examination is very important in a coma patient. It serves 3 purposes. First, to determine the cause of coma. Second, it would provide a baseline neuro exam for repeated exams later on. And third, to help determine the prognosis. It has 4 components. 1. Neurological examination in coma patients should be performed to determine state of consciousness, respiratory pattern, brainstem function, and motor reflex. State of consciousness can be determined by using various kinds of stimulation to check for arousability and awareness. Specific kind of stimulation like visual, verbal, tactile, or noxious stimulation should be recorded along with exact response to determine arousability and awareness, which helps with determining exact state of consciousness. Glasgow Coma Scale was initially proposed to determine severity of traumatic brain injury, can also be used to determine state of consciousness. Glasgow Coma Scale ranges from 3 to 15. Score less than or equal to 8 suggests patient needs to be intubated. It has 3 components: eye, verbal, and motor. Mnemonic that can be used to memorize the point scale for each component is 4 eyes for eye, Jackson 5 for verbal, and 6 Linder motor for motor. If a patient keeps eyes open spontaneously, then it's 4 points. If he opens with verbal command, then 3 points. If he opens eyes with painful stimulation, then 2 points. And if he doesn't open his eyes on painful stimulation, then 1 point. If patient tells you exact year when asked, it's 5 points. If he tells you wrong year, then 4 points. If he says God or Tuesday, then 3 points. If he moans or says ouch on painful stimuli, then 2 points. And if there is no verbal response to painful stimulation, then 1 point. If patient follows command when asked to show thumbs up, make a fist and show peace sign, then 6 points. If he localizes to painful stimuli, then 5 points. If he withdraws his arm when you pinch his fingers, then 4 points. If he flexes both upper extremities and extends both lower extremities on painful stimulation, then 3 points. If he extends both upper and lower extremities, then 2 points. If there is no movement on painful stimulation, then 1 point. Full outline of unresponsiveness score, also known as 4 score, is also been suggested to determine state of consciousness, especially in intubated patient. Normal breathing is quiet and unlabored. The presence of any respiratory noise implies obstruction. Normal respiration depends on 1. A brainstem mechanism located between midbrain and cervical medullary junction that regulates metabolic needs, and 2. Forebrain. Respiratory patterns which is helpful in localizing level of involvement include Cheyne-Stokes respiration, central neurogenic hyperventilation, apneustic breathing, cluster breathing, and ataxic respiration. Cheyne-Stokes respiration is a respiratory pattern that slowly accelerates between hyperventilation and hyperventilation, followed by a period of apnea. It is associated with lateral hemispherical, or diencephalic insult, and may occur as a result of bilateral damage anywhere along the descending pathway between forebrain and upper pons. It is also seen with cardiac disorders that prolonged circulation time. Alertness, pupillary size, and heart rhythm may vary during Cheyne-Stokes respiration. A continuous pattern of it is relatively good prognostic sign, usually implies that permanent brainstem damage has not occurred. The emergence of Cheyne-Stokes respiration in a patient with unilateral mass lesion may be an early sign of herniation. Two breathing patterns similar to Cheyne-Stokes respiration should not be confused with it. First is short cycle periodic breathing is a respiratory pattern with shorter cycle and faster rhythm than Cheyne-Stokes respiration. It is seen with increased intracerebral pressure, lower pontine lesions, or expanding lesions in posterior fossa. Biot's breathing, which is short burst of 7 to 10 rapid breaths, then apnea without waning and waxing pattern, is described as an ataxic respiration pattern, which will be discussed later. Central mnemonic hyperventilation refers to rapid breathing from 40 to 70 breaths per minute, usually due to central tegmental pontine lesions, just ventral to aqueduct or fourth ventricle. This must be differentiated from reactive hyperventilation due to metabolic abnormalities of hypoxemia secondary to pulmonary involvement. Increased intracranial pressure can also cause spontaneous hyperapnea. Kussmaul breathing is a deep, regular respiration observed with metabolic acidosis. Apneustic breathing is a prolonged inspiratory gasp with a pause at full inspiration. It is caused by lesion of dorsal lateral lower half of pons. Cluster breathing, which results from high medullary damage, involves periodic respirations that are irregular in frequency and amplitude with variable pauses between clusters of breaths. Ataxic breathing is irregular in rate and rhythm and usually is due to medullary lesion. The combination of ataxic breathing and bilateral six-nerve palsy may be a warning sign of brainstem compression. Ataxic and gasping respirations are signs of lower brainstem damage and often are pre-terminal respiratory patterns. Brainstem function in a comatose patient can be assessed by checking pupillary reflex, corneal reflex, and vestibulo-ocular reflex. Pupillary size and pupillary reflex is an important examination for brainstem function assessment. When you flash a light in the eye, both pupils will constrict, which is a normal pupillary reflex. Pupillary reflex has optic nerve as an afferent tract, which takes stimulation to the Edinger-Westphal nucleus in the midbrain, and oculomotor nerve as an efferent limb. Damage to various parts of this pathway can cause abnormal pupillary size and reflexes. Pupillary reflex is usually preserved in metabolic abnormalities, so the pupils will be small and reactive in metabolic abnormalities. Same with diencephalic injury, pupils will be small and reactive. With unilateral injury to third nerve or uncal herniation, unilateral pupil will be dilated and fixed. In a patient with midbrain injury, pupils will be mid-position and fixed. In a patient with tectal lesion, pupils will be large, fixed, and have hippus. Patient can have pinpoint pupils with injury to pons or opioid overdose. Corneal reflex can be elicited by touching the cornea with a wisp of cotton, which results into bilateral blink response. The afferent limb of corneal reflex is through 5th cranial nerve and the efferent is through 7th cranial nerve. The corneal reflex will be abnormal or absent if there is injury to either 5th or 7th cranial nerve or the nuclei or brainstem. Ocular motility, conjugate gaze, and vestibulo-ocular reflex is maintained by bilateral frontal eye field, oculomotor nerves, abducent nerves, and vestibulocochlear nerves. Vestibulo-ocular reflex can be tested by two methods: oculocephalic or Dolce maneuver or caloric test. In oculocephalic maneuver, patient's head will be turned on one direction. Normally, the eyes will move to the opposite direction. If no movement in either eye on rotating the head on either side, then it suggests bilateral pontine gaze palsy, bilateral labyrinth dysfunction, or drug intoxication. If eyes move appropriately when head is rotated in one direction but do not move when head is rotated in opposite direction, then it suggests unilateral pontine gaze palsy. If one eye abducts and other eye doesn't adduct, then it suggests third nerve palsy or internuclear ophthalmoplegia. When head is moved vertically, eyes moves on the opposite direction normally. If no movement in either eye, then bilateral midbrain lesions are suspected. If only one eye moves, then the third nerve palsy is suspected. In caloric test, either cold or warm water is instilled in both ears. We usually use cold water. When cold water is instilled in right ear, slow phase of eyes move towards right with fast corrective phase towards left. If no response, check for obstruction in ears. If no obstruction, then it can be because of dead labyrinth or 8th cranial nerve or nuclear dysfunction. If there is downbeating nystagmus, it means horizontal gaze palsy. We cannot assess motor power in a comatose patient because they do not follow commands, but we can look for indirect signs or passive signs like posture or muscle tone. Posturing is like old GPS. It will tell you the area around where the lesion can be but wouldn't be able to tell you exactly where it is. Patient can posture spontaneously or with painful stimuli. If patient has flexion posture on bilateral upper extremities and extension on bilateral lower extremity, then it is called decorticate posturing, and it usually suggests that lesion is above the brainstem. If patient extends bilateral upper as well as lower extremities, then it is called decerebrate posturing, which suggests the lesion is at the level of brainstem. Passive muscle tone can also be helpful to determine the cause of coma, like generalized muscle rigidity can be seen in neuroleptic malignant syndrome. In summary, neuroexam is very important in comatose patient. It serves three purposes: determining the cause of coma, provide a baseline, and help determine the prognosis. It has four components: state of consciousness, respiratory pattern, brainstem function, and motor response. Glasgow Coma Scale can also be used to determine state of consciousness. Various respiratory patterns can help localize lesions in various parts of the brain. The brainstem function can be assessed through pupillary reflex, corneal reflex, or vestibulo-ocular reflex. Decorticate posturing suggests lesion above brainstem. Decerebrate posturing suggests lesion at the level of brainstem. Passive muscle tone is also helpful with the diagnosis of etiology of coma. Additionally, I recommend these resources for further learning. Neurology in Clinical Practice, Chapter 5, Stupor and Coma, available as ebook at Roland Medical Library, as well as Disorder of Consciousness, Clinical Practice on Osmosis website.